In our urology Viva exit exam preparation, we are going to discuss male LUTS today. And thank you for the trainee who has agreed to record this session so that it will be a good revision tool. You have a 72-year-old gentleman presented to your clinic with voiding LUTS. How are you going to evaluate him?
So I'll see him in my dedicated LUTS clinic with a pre-filled IPSS form, 3-day bladder diary, and I'll do a flow rate and a post-void scan. On arrival, I'll take a history, examine him, and arrange some tests. In my history, I want to establish the duration, the progression of his lower tract symptoms, and how severe it is, objectively qualified by his IPSS score. I'll ask about any associated storage symptoms, any recurrent urinary tract infections, visible hematuria, and importantly, if he has any episodes of incontinence or nocturnal enuresis. I'll ask about any neurological or bowel problems, and if he's had any treatments for his lower tract symptoms. I'll document his past medical history, including and his drug history, including anticoagulation status. I'll then examine him with a chaperone, examining his abdomen for any palpable bladder, kidneys for any palatable kidneys, examine his genitalia, looking at the meatus for any phimosis or meatal stenosis, and his testicles. I'll then do a DRE, assessing the size of the prostate, feeling for any nodularity, and consistency. And after that, I will arrange some tests, including a urine dip, plus or minus culture if positive. I would also document his use and ease, if there's any concerns of kidney impairment. After appropriate counseling, I will request for a PSA.
Okay. What do you mean by Hall's rings? What are the components of it?
So this underpins the pathophysiology of lower tract symptoms. So histologically, benign prostatic hyperplasia leads to benign prostatic enlargement, which leads to bladder outlet obstruction, and ultimately lower tract symptoms. So those are the rings, and BPH is in the middle of the ring.
Okay. You're arranging the urine dipstick, it was normal. What other investigations you want?
So IPSS, bladder diary, flow rate post-void scan, as well as baseline usinase.
What are the indications for usinase in a patient presenting with voiding symptoms?
So symptoms indicative of renal impairment, such as nocturnal enuresis or urine incontinence, chronic urine retention, palpable bladder, palatable kidneys, features of edema, such as leg edema, or very high blood pressure as well would be indication for usinase.
Okay, so our patient has none of this, so we are not going for usinase.
Okay.
What is the indication for PSA?
So the indications for PSA would include LUTS, most likely secondary to benign prostatic enlargement, or an abnormal finding on DRE, or if patient is concerned and requesting for a PSA.
Okay, his PSA is 1.7. His IPSS score shows predominantly voiding symptoms with a total score of 28 out of 35 and quality of life 5 out of 6. Urine dipstick normal, as I said. What is your next step?
So he has severe LUTS, and this is significantly affecting his quality of life. So I will discuss management options with his patients, starting off with the conservative options of fluid management, and also regular voiding. And if he's got post-void dribbles, double voiding and milking his urethra can be helpful. And then moving on from that, I will, because of his IPSS score and also his age, I will start him on a combination of an alpha blocker as well as a 5 alpha reductase inhibitor.
What is the evidence behind this combination?
So this comes from the MTOPS trial, which showed that, so this was an RCT of over 3,000 patients, and it showed that compared to placebo, combination therapy was superior in terms of reduction in the patient symptom score and also avoidance of progression to urine retention or requirement for surgery. And it was also superior to monotherapy.
Any other studies which support this combination?
The PLESS was purely a monotherapy. I can't remember any other studies supporting combination therapy.
What medications was tested in MTOPS?
So MTOPS was dutasteride, doxycycline, or a combination, and placebo.
Okay. So how will you explain this to the patient regarding the side effects?
So I'll explain to the patient side effects of an alpha blocker will include postural drop and also retrograde ejaculation. So these are the ones that the patient needs to be aware of. And with regards to dutasteride, this may potentially cause some elements of maybe erectile dysfunction if he's already suffering from this. And there's also some evidence to suggest that if the patient develops prostate cancer down the line, it may be the more aggressive one. But overall, it is safe, and it will be my recommendation given his severity of LUTS as well as his age.
What is the reason for high-risk prostate cancers in men taking 5-alpha reductase inhibitors?
So it's not very clear, but there are proposed theories such and they include that the 5-alpha reductase inhibitor creates an environment where only the aggressive cancers can thrive and not the clinically insignificant ones, or that this is purely an association and not a causation.
Okay, so when are you going to review him?
So I'll reassess him in 3 months' time with an up-to-date IPSS score, a flow rate, and a post-void scan.
Okay. When you're seeing him in 3 months' time, he had some improvement in his symptoms. His IPSS improved from, say, late 20s to something around like 15, but he's quite debilitated because of the problems in libido and erection. What may be the reason, and how are you going to help him?
So this may be because of the 5-alpha reductase inhibitor, which I've commenced him on. And given that he is symptomatic from this, I will advise him to discontinue that. This may come at the cost of his low interact symptoms getting worse or potentially progressing. But I would also want to know what his quality of life score is at this point to decide if we need to go down the surgical route.
His quality of life, as you know, we started at 5 out of 6. As far as the voiding is concerned, there is good improvement, but because of the absence of erection, he is still marking as 5 out of 6. Is there any way you can help him with medications alone?
So I can counsel him on the use of BDE5 inhibitors. So we can try Viagra or Cialis to see if this addresses his erectile problems. Of which, if it does, then we can persevere and continue with the combination therapy.
What may be the dose?
So I will start him, if I'm starting him on Viagra, I will start him at a high dose of 100 milligrams once a day, and this can be titrated lower if he has significant improvements or he has side effects from that.
Okay. Is there any specific medicine suitable for people with male LUTS?
Yes. Cialis which is tadalafil, is actually recommended for men with LUTS, as it does have some benefits, as well as benefits from erectile function. So this would actually be my preference.
Okay, that's very good. Well done. The time is up now.
Okay.
No major concerns. Nice flow. Just only few picks here and there. I will say regarding the bladder diary, I will specifically mention it is more useful if the patient has any storage symptoms, because for avoiding
Okay.
symptoms, IPSS is enough.
Yep.
Don't use the trade names of Cialis or Viagra. Try to use sildenafil,
Yeah.
tadalafil.
Yeah.
In this
The
particular,
reason I say that, I forgot tadalafil, so I just
Okay.
wanted to say something to help me remember. So,
Okay.
and as soon as I say it, then I remembered the generic name. But
Yeah.
yeah,
Because
point taken.
the tadalafil 5 milligram is very specific for male LUTS. Even though the NICE
Yes.
guidelines haven't approved it, there are plenty of literature to support that monotherapy 5 milligram tadalafil once daily is a good one.
Yeah.
And in the MTOP study, the drug studied by doxycycline and dutasteride.
Yep.
And in combat study, the another combination treatment medicine, the drug study
Was finasteride,
finasteride, and it's like it's a bit of a very peculiar combination. It's like a tamsulosin and dutasteride, another one doxycycline and finasteride, which we never use in that combination. So remember the combat trial. Otherwise, I think you did very well. Any queries from your side?
No, I think I progressed through the station. I guess subtle points like when he had ED, maybe he should have clicked straight away that tadalafil was the next thing to give him, and without prompting. So,
Yeah. And the Hall's ring, just you may have been even asked to draw the rings. So there are 3 rings: bladder outlet obstruction in the top, benign prostatic enlargement on LUTS in the lower 2, and they overlap each other, forming different combinations. So you should be able to draw and reproduce the ring. I have placed the ring in the YouTube link, which I will send you later today.
Yep.
Good. Well done.